I see now that you are recording also.
Yes, sir.
Did we record the initial 2 MCQs?
للاسف يا دكتور ما لحقناش نعمل لهم ريكورد كلهم.
Okay. Can we start?
Go ahead sir. تمام يا دكتور توكل على الله.
Okay, I'm starting. So this question, after we discussed the keywords and key signs and symptoms, was very easy for us now. Of the following, the most likely underlying cause of ascites in this infant is congenital lymphatic malformation or congestive heart failure or ileal atresia or posterior urethral valve. And all these conditions can cause ascites. Based on the scenario in the vignette and the labs and the analysis of the ascitic fluid and clinical exam of the baby, which is the correct answer?
ileal atresia, doctor.
Ileal atresia, but all can cause ascites. And now let us go to the critique. Go to the critique. Okay. Neonatal ascites is characterized by an abnormal accumulation of peritoneal fluid, which can lead to multi-system deterioration. It can cause, because it's causing a massive pressure on each organ, even the heart and lungs, in addition to the abdominal organs. Urinary ascites, urine ascites is common in the newborn babies. And ascites due to underlying GI condition are common types of ascites in the newborn. So they come first in your differential, urine ascites and GI problems. Acidic fluid can be transudate or exudate, distinguished by serum acidic fluid albumin gradient. By the albumin gradient between the serum albumin and acidic fluid albumin. The serum acid, but we didn't use this in the vignette. I don't know why he didn't let us know about what was the serum albumin. The serum acidic fluid albumin gradient is the difference in serum and acidic fluid albumin concentration. If it is more than 1.1, it suggests transudate. So you think of like cardiac causes, portal hypertension, whatever. And if it's less than 1.1, it suggests exudate, meaning there is inflammation, infection, peritonitis. And going from there, we go to the critique. Fetal ascites, because the baby started ascites in utero. Fetal ascites is defined as an abnormal accumulation of fluid within the fetal abdominal cavity. It can be isolated finding or can be associated with accumulation of fluid in other body cavities. And in this case, it will be hydrops. All causes of hydrops can lead to isolated fetal ascites, but we'll not call them hydrops, with the more common mechanisms as described in the table. Before we end this MCQ, we'll go to this table and see what are the different possible causes of ascites. Neonates with ascites may have massive abdominal distension, which may lead to respiratory compromise. Paracentesis serves not only as a diagnostic procedure, but also maybe therapeutic. Acidic fluid can be an exudate or transudate, and it distinguished by the serum acidic fluid gradient, as we mentioned. A physical exam may further assist in determining the diagnosis. of the underlying cause, whether it's cardiac, genetic, whatever. Additional evaluation typically includes abdominal ultrasonography. So these are the labs and imaging and procedures you need to do in addition to what was mentioned in the vignette. Abdominal ultrasonography, chest radiography, echocardiography. Blood tests may include CBC, electrolytes, renal function, liver panels, screening for viral infections, chromosomal analysis, and of course, you should check for serum albumin. Fetal ascites and polyhydramnios were present in the case in the vignette. The neonate's physical exam findings are notable for abdominal distension, absence of bowel sounds, with abdominal radiography revealing paucity of the distal bowel gas, and there is pneumoperitoneum. Okay? A paucity of distal bowel gas, pneumoperitoneum, and the elevated acidic fluid cell count suggests an inflammatory response consistent with peritonitis. So we are dealing with an exudate. The most likely underlying cause of the ascites in this baby is ileal atresia. And then with ileal atresia, there is obstruction, which causes meconium, peritonitis secondary to perforation. And one of the signs of meconium peritonitis with perforation that we didn't see in this baby is, anybody knows?
Calcification.
Yes, abdominal calcifications after the baby is born. Yes, this is important radiologic finding. So this is how they read the babygram. The paucity of bowel gas pattern, and there is a pneumoperitoneum. And this is shown by the arrow, okay? Which is a small amount, but not massive amount because of the massive effusion. An underlying GI condition is one of the two most common causes. We said that the two most common causes of ascites are urine ascites and GI problems. Fetal atresia or obstruction may lead to dilation of the proximal, and he's going to talk about polyhydramnios. And then the most common cause of urine ascites is
posterior urethral valve.
Yes, posterior urethral valves. Yes, bravo عليك. And then we're going to talk about the lymphatic drainage of the GI and how if there is acidic, there is a lymphatic fluid causing ascites, what we are going to see. And then congestive heart failure, how we can cause ascites and what are the characteristics of that. I will send all this to you. And then this is the table that shows you what is the system and what are the clinical conditions and the mechanism. And you see that urinary and GI come on top of the list, but there is other causes like cardiac infectious, and there is different conditions and different mechanisms. And I will send all these tables to you. And this is the rest of the table. It also shows other causes, lymphatic, metabolic, hepatic, genetic. So it's a long list of conditions. And then comes genital, like in a girl with ovarian cyst, iatrogenic, if secondary to the TPN in a UVC. It can cause ascites, can cause pericardial effusion, can cause pleural effusion. So be careful about leakage of TPN in a baby who's having central line, because central lines move. They move. and they can penetrate other organs and other tissues, and can, when you have a baby who has a central line and is on TPN and he crashes on you, think of pericardial effusion, pleural effusion, ascites. You have to rule them as soon as possible. Or iatrogenic, hematologic, if you have, this is in case of immune hydrops, or neoplastic because of malignant cells in the peritoneum, or idiopathic. Sometimes you don't find a reason. Questions, comment? Any questions or comments?
دكتور أنا عندي سؤال. إحنا يعني شفنا كذا حالة فعلا عندها intestinal obstruction وأسايتس وintestinal perforation، وأول ما بتدخل عمليات والجراحة يعني بيدخلوا فيها زي الأسيتيك فلويد مرة واحدة بيبقى ريليف أو بيحصل زي losses of fluid. بالظبط بالظبط، والحالات دي ما بتعديش، فانا مش عارفه هل في حاجه معينه بتتعمل. يعني انا كنت بقول يعني لو الحالات دي اتعمل لها gradual birth.
I will let you know why. Because once they are in the OR, they are taken care of by the anesthesia. And the anesthesia team, they are very competent. I'm not criticizing their skills, but they are not neonatologists. So to prevent that, you have to be involved from A to Z, even in the OR. And you have to follow these babies carefully, monitor vital signs and monitor labs, and be very cautious. And the surgeon should get the fluid out as slowly as possible. And the anesthesiologist should replace the fluids as soon as possible. Dealing with fluids and electrolytes is a major problem in Egypt. In all intensive care units, taking care of children or adults. And I have many friends who experienced it, who had very bad experience when they were in the intensive care unit, because unfortunately the fluid management is not appropriate. And one of my dear colleagues died because of mismanagement of his fluids in an ICU. I think you have to be involved from the get-go. You have to monitor your baby as much as you can, vitals, blood pressure, and don't allow blood pressure to drop. If it drops, meaning that you are in an advanced case of shock. If there is tachycardia, it's a warning sign. So please, dear surgeon, don't take much fluids. Please, dear anesthesiologist, give enough fluids. Fluid resuscitation is extremely important for newborn babies and for any patient in an ICU. Did this answer your question?
يس دكتور، هو فعلا اعتقد ان هم كانوا صراع جدا في ان الفلويد يطلع من البيبي. كان المفروض فعلا يعملوا gradual withdrawal of fluids، او يعني لازم، يعني هم فعلا بيبقوا مش oriented بالحتة دي، وبيزعلوا قوي بتوع التخدير لما بندخل معاهم او بنكلمهم يعني. بس احنا هنحاول برضو ن overcome الموضوع ده.
Involved, and you should take the upper hand in the management. And this is not something that will make them like underestimated or whatever, but you should have a plan with them in advance. You should sit with the surgeon and with the anesthesiologist, and you should have a plan, and you should be involved from the get-go. And you should take care in the monitoring of your baby in the OR with the anesthesiologist, with the surgeon, and you should work as one team. As one team. Okay? Fluid management is
دكتور
extremely important.
شكرا لحضرتك.
العفو. حضرتك,
may
we
I
might
ask a
be able
question?
to take another question, and then we'll, because we are almost 1 hour now. Okay. A neonate is born at, I don't think this is going to be a long one. A neonate is born at 24 weeks after preterm labor. So mom started preterm labor. And when there is a preterm labor, you have to think of what is the most common cause of preterm labor?
Infection.
Infection. The mother was febrile and hypotensive. Okay, the mother was sick, really sick and febrile. Maybe she had infection. And the fetal heart rate tracing was non-reassuring. This is bad. Amniotic fluid delivery was brown stained. So we have maternal illness. Mom was febrile and hypotensive, and she went into preterm labor, and amniotic fluid was brown stained. Apgar scores 1, 2, and 4. Very bad Apgar scores. Diagnostically and prognostically, this baby was very, very sick. Laboratory evaluation of the neonate demonstrated this baby had thrombocytopenia, leukocytosis, elevated C-reactive protein. Gram stain of both maternal and neonatal blood cultures were positive. Oh, both mom and baby had bacteremia and septicemia, which is blood culture. I don't see the arrow. Blood cultures from both mom and baby. And they showed gram-positive bacilli. Gram-positive bacilli. When you hear gram-positive bacilli, what you think of, because this is the key of this case. The neonate has a rash, tiny pale patches on an erythematous base. Skin biopsy demonstrated microabscesses in the skin causing skin rash with the same gram-positive bacilli. Placenta had usually for every and each preterm baby, or when you suspect that mom had infection, the placenta should be sent to pathology. I don't know if you do this practice in Chatbi or not. Dr. Marwa Duda, liver and liver guys send placenta for pathology.
للأسف لا يا دكتور، للأسف لا، مش available عندنا يعني. هو ممكن نعملها بس it's on يعني
the problem is
يعني
that the placenta is not yours. It's not. It is theirs.
لا هما يعني بالنسبة للنساء يعني صعب. وكمان يا دكتور احنا عندنا تقريبا 70 حالة ريسكي ديليفري بتتولد في اليوم، فيعني هيبقى صعب شوية ان نعمل كم الباثولوجي ده الحالات. احنا بالعافية بنعمل الحالات اللي محتاجة فعلا يعني تيومر ريسكتد من نيوبورن، يعني بالعافية بنعمل لدول يعني.
Okay, this is not a good practice. There was diffuse intense inflammation with diffuse also microabscesses. Maternal and neonatal blood culture results confirm underlying infection. Of the following during pregnancy, this mother most likely عملت حاجة غلط. So what we are dealing with, if we collect these key points that started during pregnancy with a very sick mom and very sick 24-weeker delivered early that had evidence of infection, microabscess in the skin rash, thrombocytopenia, leukocytosis, elevated C-reactive protein, positive blood culture, positive maternal blood culture, positive placental pathology, and all show diffuse microabscesses, and there is isolation of gram-positive bacilli. What are we dealing with?
ممكن يبقى جروب بي ستريبت.
دكتورة مروة معلش استني حضرتك شوية. انت بتقولي ستريبتوكوكاي and this is bacilli.
نيبي يا دكتور ممكن تكون ليستيريا يا دكتور؟
ستيب.
Yes, it is listeria. And as we are going to see in the critique, diagnosis of listeria is not easy. And
Yes.
when you send sample to the lab, microbiology lab, you should let them know we are suspecting listeria, because if they don't look for it, they will misdiagnose it as cocobacilli, diphtheroids, as we are going to see in the vignette. So this baby has the mother and the baby, which is something very serious, had infection with listeria. And everything points to this is a classical textbook case of listeria infection. From the history, from the fluids, from the amniotic fluid, from the clinical presentation, from the labs, gram stain, cultures, placental pathology, mother. This is a classical textbook of listeria. I don't know, Dr. Marwa, do you see cases of listeria in الشاطبي?
لا ما طلعش عندنا cultures قبل كده positive للستيريا.
But they don't look for it, as we are going to see in the critique. So the question is, question أصعب بقى أغلس بقى. يعني أنت عرفتي إن أنت هي listeria and you are excited and happy, and then you find a silly question of the following: during this pregnancy, this mother most likely acquired kittens, consumed unpasteurized milk 3 weeks before delivery, underwent circulage, placement for cervical incompetence, worked at a daycare center.
Unpasteurized milk.
Unpasteurized milk.
Bravo عليك, yes. Acquired kittens when we are thinking of?
Toxoplasma.
Yes. Consumed unpasteurized milk 3 weeks? Yes, listeria. Underwent circulage? What usually you find when the mom has circulage?
GPS.
No, it makes the mother, huh?
Herpes.
HSV, no. HSV is a venereal disease. She should have venereal disease, HSV. No, it's a fungal infection. And worked at a daycare center. Like you are working in a nursery, and the nurses are liable. That's why I'm telling you, please, you have to wear gloves, please. It's not only for the safety of the baby and not to transmit infection. It's for on your own safety, especially if you have a pregnant lady working in the NICU. Please don't touch the baby. Don't clean the baby. Don't take rid of the baby urine and stools with your own hands. Please wear gloves. So what is the high risk for a mother working at a daycare center, especially if she's pregnant? What comes from urine of babies and children? CMV infection. You should be aware of that. Okay. The relative T cell deficiency associated with pregnancy increases the risk of acquiring listeriosis during gestation. Listeria is not part of the normal vaginal flora. So it's something weird when you have listeria affecting the baby and even the mother. It is not part of the normal vaginal flora like the GBS. Hence, its presence in neonatal samples reflects invasive infection. It invasive transplacental infection more than an ascending infection from colonization of the genital tract of the mother. And high clinical suspicion regarding neonatal listeriosis should be communicated directly to the lab to both obtain direct gram stain and relevant specimens and decrease misdiagnosis. Usually they misdiagnose it as diphtheroids or streptococci or cocci. So please, when you send a culture, ask the lab or let the lab know you are because of the clinical scenario, we are suspecting possibility of listeriosis. Can you please check for listeria? And it's before you send us that report of diphtheroids or streptococci. Pregnant persons should, and you notice they said pregnant persons and did not say pregnant mothers. Do you know why? This is something that the only good deed that Trump did was related to this issue. You know why they say pregnant person in America and not a pregnant mother or a pregnant woman? Because according to the LGBT, whatever issues that in America, that there is male, female, transgender, there is a homo, there is whatever. You are not allowed to talk or judge the sex of any person. So to make your side, you make yourself in the safe side, you say a person. You say a person. You don't say pregnant woman, because this person is a general referral to the human beings, which might be male, female, or in between. But now I think after Trump came, this was the only good deed he did. Okay, never mind. This is not part of the question. Pregnant persons should be educated regarding preventing dietary habits to minimize the risks of listeriosis, including avoidance of consuming unpasteurized milk and soft cheese, which comes from unpasteurized milk, as well as safe handling. And I believe in Egypt, unpasteurized milk is consumed by many, many people who cannot buy or who live in the countryside and they have the milk available directly from the cow to the table. Okay. And then the critique will talk about the listeriosis and listeria in details, and I will send this all to you. Okay. I'm going to stop at this point for the MCQs, and I hope we have time to give you some index of suspicion and visual diagnosis. Any questions before we go? Okay, our index of suspicion and MCQ is straightforward, but it's going to discuss very important topics that you deal with in everyday practice. So this end case is an easy case. It's 12-day-old infant presenting with eye discharge. When you have a newborn baby with eye discharge, what is your concern? What is the concern diagnosis?
chlamydia.
If it is ophthalmia neonatorum, if it's neonatal conjunctivitis, if it is purulent, if this discharge is purulent, okay? And then if the discharge is purulent, here comes the concern. And what are the differential diagnosis of ophthalmia neonatorum or purulent eye discharge in the newborn baby? What is your differential? Somebody mentioned something about chlamydia. And we are going to discuss how chlamydia presents and how you can treat chlamydia. What else?
Gonococcal.
Yes, gonococcal conjunctivitis, which is something very concerning. Why it's concerning? Because it's considered part of a systemic infection. And this baby should be admitted to the NICU and should receive systemic IV antibiotics. And what else?
الهربس يا دكتور neonatal herpeticum disease.
Yes, herpes. Neonatal herpes could present with eye, with skin, with mucous membrane, with systemic, or with CNS, or with all of the above. So you should be sure this is not HSV. And then comes other bacteria, GBS, staph, and comes chemical irritation because of the, sometimes some people used to use silver nitrate to the eye. And so is it in your practice that you give prophylactic erythromycin ointment for every and each newborn baby immediately at the time of delivery? Dr. Marwa, do you do that?
ممكن معلش ممكن السؤال تاني يا دكتور؟
Is it in your practice that you give erythromycin eye ointment for every and each baby immediately after delivery?
احنا بندي توبرين اي دروبس.
Okay, so you are giving something, and I believe it should be helpful. Okay,
For 5 days.
I will go through this case very rapid because it's because of the time frame and because it is just discussing a very common practice. I don't know, Dr. Marwa, do you see cases of ophthalmia neonatorum? I believe yes, a lot.
Yes, we see cases, but usually not on day one. يعني
It depends. It depends on the etiology, and this is what we are going to deal with. And this is a 12-day-old. Yes, it's very, very unusual to have a baby delivered with ophthalmia neonatorum. Usually it needs time. So this is a 12-day-old full-term female, presents to the hospital with eye discharge 1 day before presentation. So it was at the age of 11 days. She developed left-sided upper lid edema. On the day of presentation, day 12, this progressed to bilateral. Started on the left, now it's bilateral. It started with eyelid edema, and now it's mucopurulent discharge. It's ophthalmia neonatorum, and was worse in the left eye. She had no fevers. You should rule out systemic manifestations because it could be part of a systemic infection. Lethargy, increased work of breathing, abdominal distension or rash. She is feeding well, formula, and adequate urine output, well hydrated, and normal activity. Maternal history is notable for genital herpes, but these lesions developed before pregnancy and was adequately treated with acyclovir. But the problem with his herpes is that it can it can recur. So be careful about that. But she received valacyclovir suppression therapy. A sterile speculum examination before delivery was negative for active lesions. So at the time of delivery, she didn't have active lesions. There is no maternal history of Neisseria, gonorrhea, chlamydia, trachomatis, which is also a venereal disease. Prenatal care was adequate and notable for GBS colonization. Appropriate peripartum maternal penicillin prophylaxis was given to the mother, and baby delivered vaginally at 39 weeks and received neonatal conjunctivitis prophylaxis, which is what we give here is erythromycin. And she had a good course, and the baby was doing well, but she had this bilateral ophthalmia neonatorum. You see what they did for this? You will be astonished. Given copious this drainage, left edema, age of presentation, initial concern for ophthalmia neonatorum prompted a sepsis evaluation. They did complete sepsis evaluation, including CBC and DEF, C-reactive protein, urinalysis, urine culture, blood culture, and they did lumbar puncture, they did LP, and they did CSF exam for everything, including the HSV. And they did a test for gonorrhea, and they did examine the eye discharge by Grammet stain and by all other labs to rule out gonorrhea, CS, chlamydia, and HSV. And a few words about this case. In the United States, neonatal conjunctivitis affects 1% to 2%. The typical pathogens include Streptococcus pneumonia, staph, Haemophilus, like any other infection, and chlamydia, gonorrhea, Pseudomonas, HSV. Okay, and in this case, the diagnosis was weird. It was very rare organism called Neisseria cinerea, which, when they reviewed the literature, they found it's very close to Neisseria gonorrhea, and they treated it the same way. And so what are the lessons from this case? Neisseria gonorrhea typically presents on day 3 to 5. Dr. Amaro was talking about the onset, and this is how they present. Neisseria gonorrhea usually 3 to 5 days. Chlamydia usually presents late, 5 to 14 days. And HSV type 1 and type 2 presents on day 14 after birth. Okay, so what they do is they do a universal erythromycin prophylaxis, but this is not going to protect against Neisseria. That's why this baby, although received the erythromycin eye ointment, developed ophthalmia neonatorum. Actually, it was just conjunctivitis, and they ruled out ophthalmia neonatorum, which is a part of a systemic infection. And please, somebody might have this article, ophthalmia neonatorum and neonatal conjunctivitis, and prepare this article. And they found out this Neisseria organism. Okay. Do you want to stop at this point, or do you want to proceed? We are almost close to 1.5 hours. Do you want to see a visual diagnosis?
يا ريت يا دكتور، يعني ممكن لو في حاجة سريع.
Okay, I will give you also a very short one that is very, very easy. Newborn with microcephaly, and this is going to open the article of, we are going to discuss microcephaly, which is important. I believe you see many babies It's not, I don't say many, but you see babies with microcephaly, correct?
Yes.
Yes, and this article is the idea behind this article is that it will give you the differential diagnosis, because microcephaly is either primary, genetically determined most of the time, or secondary. And the presentation and the long-term symptoms and signs of microcephaly are very, very variable, depending on how bad is the brain, how much is the brain affected. And based on that, the baby could be severely delayed, could be close to normal or even normal. Or he might present the cause, the primary cause of the microcephaly, which might need treatment also. Okay. The case. This is a preterm female born at 32 weeks. Came to the NICU with respiratory distress. Came for another reason. So the prenatal histories, mom is 21-year-old, gravida 3, para 3, white. And usually they say if it's white or black, usually they use this terminology here. History of 2 previous preterm deliveries, a male neonate at 31 weeks and a stillborn at 31 week and stillborn at 21. Mom has anxiety, depression, bipolar disorder. She has all the psych problems. Irritable bowel syndrome, interstitial cystitis. Poor mom. She is on tons of medications. I don't know most of them. Acetaminophen, cyclopentapyrine, hydroxyprogesterone, caproate, hydroxyzine, calcium citrate, linoclotide, pentosane, polysulfate, sodium oxybutyrine. This is the only one I know that is for bladder irritability. Amitriptyline, whatever. I don't know most of these drugs. Pregnancy complicated by short interconceptual interval. So she got pregnant in a short time after the previous pregnancy. Abnormal 1 hour glucose, but she had normal 3 hour glucose. So she was not diabetic. Presented to the hospital in preterm labor. She received penicillin and betamethasone before delivery. Penicillin might help, but betamethasone was late. Rupture of membrane less than 1 hour. Prenatal laboratory findings, GPS colonization unknown, HIV negative, hepatitis serous antigen negative, gonorrhea negative, chlamydia negative, RPR, rapid RPRN is negative, which is for syphilis. Estimated gestational age 32 weeks and 2 days. And spontaneous vaginal delivery, resuscitation in the delivery room, tactile stimulation, oropharyngeal suctioning. She had CPAP with 40% oxygen for 10 minutes only, followed by intubation. So the baby required intubation. The female placed on SIMV in the NICU, and at the age of 1 hour, APGARs were 6 and 8. Presentation in the NICU, antibiotics, infant's respiratory distress improved. She underwent extubation to 4 liters per minute nasal cannula. So they can extubate to nasal cannula. I don't know if you do this practice or not. You don't have nasal cannula. Okay, I'm sorry. At 1 week of age. And then photograph of the let's go to our problem. Infant was taken. This is the baby, and her birth head circumference was less than 10th percentile, and actually it was less than the 10th, and then dropped below drop below the third percentile also. While other birth measurements were appropriate, okay? And this microcephaly persisted over time, and enteral feedings were started on day 2, and she did well on the feeds. Heart rate was 144, respiratory 53, blood pressure is so, oxygen 94%. Now she is in room air and setting 94%, normal temperature. Birth weight 1810, which is okay, 48th percentile. Current weight compared to birth weight is 50 gram loss, which is only 2.7%, which is okay. The birth length is also appropriate, but the problem was only in the head. The baby had respiratory distress that resolved, otherwise did not have any other problems. So this is the key for the diagnosis of this case. The baby is alert, awake, responsive, not in distress, and the head circumference is now ranging between the 3rd and 10th percentile, which is not normal. And they didn't mention how a standard deviation, how many standard deviation below the mean. They didn't mention that. I don't know why. Oral cavity is okay. Lungs are clear. The baby is asymptomatic. So this is the X-ray, which didn't show any abnormalities except the microcephaly, no calcification, no other problems. Heart is okay, genitourinary is okay, abdomen normal, musculoskeletal normal, skin is normal, neurology is important. Response to stimulation present, no focal defects, symmetric and normal Moreau reflex. All laboratory tests are normal, and meconium drug screen is negative. And what is the I cannot say drug, but there is something, if the mom is using too much, will affect the head of the baby.
Alcohol.
Fetal alcohol syndrome has microcephaly. Urine CMV and PCR negative. So everything is negative except the small head. So what is the differential diagnosis of microcephaly? What is the differential diagnosis? Which was most of them were ruled out by this scenario. What is the differential?
دي congenital rubella يا دكتور.
So congenital infection, then they rule this out. What else? It's either primary or secondary. It's either primary, genetic, or secondary. Secondary, like rubella syndrome, or congenital infection, CMV, toxoplasmosis. What else?
Craniosynostosis.
Craniosynostosis.
Craniosynostosis, yes. Yes, craniosynostosis. So this is the differential. Craniosynostosis, congenital intrauterine infections, migrational neuronal defect, and this is diagnosed. You should do MRI to see if this baby has holoprosencephaly, lysencephaly, schizencephaly. These all are called migrational neuronal defects. And if the baby has one of those, usually intellectual functions are impaired. Neurologically, he will have symptoms and signs, which is not the case. Primary or congenital microcephaly, I believe we are dealing with this diagnosis. MECP related severe neonatal encephalopathy. This is inborn error of metabolism. So the actual diagnosis, by ruling out all other issues, was primary or congenital microcephaly. And he's going to talk about this. And to make a long story short, because I will send all these to you, you should do CT and MRI to rule out these neuronal migration problems. And this baby should be followed up Okay. What the experts say, the exact prevalence of primary congenital microcephaly is not known because it's more common in Asian and Middle Eastern populations. So you should see many of those, Dr. Amaro, correct?
دكتور هو اوريدي احنا عندنا حالة دلوقتي موجودة في الوحدة و يعني يعتبر بريشس بيبي، يعني البيبي اللي قبليه توفى وده بيبي only living child وعنده مايكروكيفالي، واحنا we ruled out كل الكونجينيتال انفكشن، وهو فعلا ممكن يكون برضو ماشي مع نفس السيناريو بتاع البيبي ده.
Okay, so it will be a good idea if one of the residents prepare, like, it's a very tiny article, microcephaly. It's an easy, straightforward. Okay, so the exact prevalence is not known, but it's prevalent. It's more common in Asian and Middle Eastern, in like Egypt. The annual incidence in the white population is reported to be about 1 in million, but maybe more common in Egypt. It's considered as an autosomal recessive disorder. That's why this family has this weird family history, with the phenotype not being observed in carriers. Occasionally, this condition may not be inherited, so it may be idiopathic, but most of the time it's genetically determined autosomal recessive. So this family is at risk for having another baby with microcephaly, and they should have good genetic consultation. So please consult the genetics for this baby. Many genetic variations have been associated with primary microcephaly. However, the phenotypic appearance is similar with the variable severity of findings. So yes, the findings are very, very variable and might be severe, might be less severe, or even not at all. And he's going to talk about what genes and what are the genes. Okay. Clinical findings, as stated before, combined with brain imaging. And the problem is the size of the brain reduced or not, if there is other associated neuronal abnormalities. This is going to determine the outcome. Infants' MRI did not demonstrate signs of decreased brain volume, which is extremely important sign. Did your baby, Dr. Marwa, has MRI? Dr. Marwa, did you hear my question? The baby that you have in the NICU should have an MRI, okay? And you should have a genetic consultation.
والدكتور اوريدي احنا حجزنا له CT و MRI.
Okay. So I will not go further, and this is a good article to present. And I'm going to stop at this point. Any questions or comments?
شكرا يا دكتور.
So next Wednesday is going to be respiratory distress in the newborn.
ايوه يا دكتور
يا دكتور
ان
إن
شاء
شاء
الله.
الله.
Is the doctor presenting with us today?
هي هتكون في ريال يا منال؟
لا يا دكتور مروة، هتبقى رواق إن شاء الله، هي اللي هتقدم الريسبيراتوري ديستريس ان نيو بورن.
Is she with us today?
هي مش معانا، لكن معاها دكتورة منال المفروض اللي هي سوبرفايزنج يعني البرزنتيشن حاضرة معانا.
Okay, so inshallah we meet Saturday. So I hope we can meet early, and I hope everybody should be available.